Good morning, everyone. Myself, Dr. Rakshit Telse, and today I'm going to present a seminar on trigeminal nerve. The contents which we are going to learn are introduction, nuclei, functional component, cores, trigeminal ganglion, division of trigeminal, and its applied aspects. Now let's start with introduction. It is the largest cranial nerve, and embryologically, it is during the development of embryo, the pharyngeal arches appears in fourth and fifth week, and the trigeminal nerve is derived from the first pharyngeal arch. It contains both sensory and motor fibers, and its three main branches are ophthalmic, which is called V1, maxillary, which is called V2, and mandibular, which is called V3. And now its nuclei. It has four nuclei, three are sensory, and one is motor nucleus. So one is main sensory nucleus, spinal nucleus, mesencephalic nucleus, and motor nucleus. As we can here see here. This is main sensory nucleus. Above it is mesencephalic nucleus. Below it is spinal nucleus. And just medial to is one motor nucleus. So let's start main sensory nucleus. It is present in the upper part of pons, lateral to the motor nuclei, and it continues below with the spinal nucleus and above with mesencephalic nucleus. Spinal nucleus, it descends from the main sensory nucleus in the pons through whole of medulla oblongata and into upper two part of spinal cord. Mesencephalic nucleus, it is present in the lateral part of central gray matter of midbrain and extend down in the pons up to main sensory nuclei. And motor nuclei, it is present in the upper part of pons medial to sensory nucleus. Now its functional component, it has two components, sensory component and motor component. Sensory component is general somatic afferent, that is course up to general somatic afferent nuclei, from somatic afferent to thalamus, and from thalamus to cerebral cortex. And motor component, it is connected to motor component cortex of both sides through corticonuclear tract. Now let us start with sensory component, that is course up to general somatic afferent nuclei. The fibers of this trigeminal nerve carries exteroceptive sensations, that is pain, touch and temperature, and relays in trigeminal ganglion. Now the sensory root fibers, after reaching the pons, it runs dorsomedially towards the main sensory nucleus and divides into ascending and descending branches. Ascending branch ends into main sensory nucleus and descending branch terminates into the spinal nucleus. Now the termination of these sensory fibers is as below. Fibers carrying sensation of touch and pressure, it terminates into the main sensory nucleus here. And the fibers carrying pain and temperature terminate into the spinal nucleus. And it divides as follows: from ophthalmic division in the inferior part of the nucleus, from maxillary division in the middle part of nucleus, and from mandibular division in the superior part of the nucleus. Now the sensory fibers carrying proprioceptive impulses from the facial and extraocular muscles and muscles of mastication, it bypasses the trigeminal ganglion and relay directly into the mesencephalic nucleus. Now course from general somatic afferent nuclei. Now, what happens here? The axons of the neurons in the main sensory and spinal nuclei and central processes of the cell in mesencephalic nucleus that crosses the midplane and ascends as trigeminal lemniscus to terminate on the nerve cells of the ventro-posterior medial nucleus of the thalamus, from where it reaches to the cerebral cortex. Now, course from thalamus to cerebral cortex. The axons of the ventro-posterior medial nucleus of the thalamus travels through internal capsule to the posterior central gyrus, that is area 3, 1 and 2 of Brodmann's area of the cerebral cortex. Now motor component. The motor nucleus is connected with the motor cortex of both sides through corticonuclear tract. And it also receives fibers from the reticular formation, the red nucleus, the tectum, and the medial longitudinal fasciculus. In addition, it receives fiber from the mesencephalic nucleus, thereby forming a monosynaptic reflex by which proprioceptive control over the masticatory muscles is exercised. Now post. The trigeminal nerve emerges from the anterior aspect of the pons as a small motor and a large sensory root. The nerve passes forward out of the posterior cranial fossa and rests on the upper surface of the apex of Peter's part of temporal bone in the middle cranial fossa. And it pierces the dura mater under the attached margin of the tentorium cerebelli and joins the posterior concave border of the trigeminal ganglion here. Now the trigeminal ganglion, it is the sensory ganglion of the fifth cranial nerve. Its shape is crescentric or semilunar with its convexity directed anterolaterally. The three divisions of the trigeminal nerve emerge from this convexity. Here we can see ophthalmic, maxillary and mandibular. The posterior concavity of the ganglion receives the sensory root of the nerve. Here we can see it. Now the location of the trigeminal ganglion. It is present on the apex of the petrous temporal bone. It occupies a special space of dura mater called the trigeminal or Meckel's cave. There are two layers of dura below the ganglion. It is outer layer of dura mater and this is inner layer of dura mater. And it is like the cave is lined by pia aragonite so that the ganglion along with the motor root of the trigeminal nerve is surrounded by CSF. Now the relations, medially internal carotid artery and posterior part of cavernous sinus is present. Laterally middle meningeal artery is present. Superiorly uncus and temporal lobe and inferiorly motor root of fifth nerve, greater petrosal nerve, apex of the petrous temporal bone and the foramen lacerum. Now the division of trigeminal nerve. The peripheral processes of neurons of trigeminal ganglion forms three divisions. Here is the ophthalmic nerve, maxillary nerve and mandibular nerve. Ophthalmic nerve contains only sensory fibers and then leaves the skull through superior orbital fissure to enter the orbital cavity. Maxillary nerve also contains the sensory fibers and leaves the skull through foramen rotundum. And mandibular nerve contains both sensory and motor fibers and leaves the skull through foramen ovale. The small motor root of the trigeminal nerve joins the mandibular nerve. Here we can see the principal nucleus, spinal nucleus and mesencephalic. These all are sensory nucleus. This gives branch to ophthalmic nerve that exits through superior orbital fissure. One goes through maxillary nerve goes through exits through foramen rotundum, and mandibular nerve exits through foramen ovale along with the motor nucleus. Now ophthalmic nerve. It is the smallest of the three divisions. Here it is ophthalmic, smallest of the three divisions. After arising from the ganglion, ophthalmic division lies in the lateral wall of the cavernous sinus, where oculomotor and trochlear is present superior to it, and abducens nerve is medial to it, and maxillary nerve is inferior to it. In the anterior part of the cavernous sinus, it divides into three branches, namely lacrimal nerve, frontal nerve, and nasociliary nerve, which enters the orbit through the superior orbital fissure. Here we can see branches of the ophthalmic, frontal nerve, nasociliary nerve, and lacrimal. Now the lacrimal nerve. It is the smallest of the three terminal branches of the ophthalmic nerve. It enters the orbit through lateral part of the superior orbital fissure and runs forwards along the upper border of lateral rectus muscle in a company with lacrimal artery. The lacrimal nerve supplies the lacrimal gland, conjunctiva, and upper eyelid. Now the frontal nerve. This is the largest of the three terminal branches of ophthalmic nerve. It begins on the lateral wall of the anterior part of the cavernous sinus. It enters the orbit through the lateral part of superior orbital fissure and runs forward and on the superior surface of LPS muscle. At the middle of the orbit, it divided into two branches, that is supratrochlear and supraorbital branch. Supratrochlear is present medially, that goes upwards and passes backwards. And supraorbital branch, it, it is present lateral to supratrochlear, it passes upwards and divides it into medial and lateral branches. Here we can see supratrochlear now emerges from the orbit above the trochlea. It supplies conjunctiva, upper eyelid, and small area of the skin of the scalp. And supraorbital nerve, it emerges from the orbit through the supraorbital notch of foramen. It divides into medial and lateral branches which run upward over the forehead and scalp. It supplies the conjunctiva, central part of the upper eyelid, frontal layer sinuses, and the skin of the forehead and scalp up to the vertex or even up to the lambdoid suture. Now the nasociliary nerve, it is one of the terminal branches of ophthalmic division of trigeminal nerve. It begins at the lateral wall of anterior part of cavernous sinus. It enters the orbit through superior orbital fissure and it crosses above the optic nerve from lateral to medial side along with ophthalmic artery and runs along the medial wall of orbit between superior oblique and medial rectus. Now the branches of the nasociliary nerve, that is anterior ethmoidal nerve, posterior ethmoidal nerve, long ciliary nerve, and infratrochlear nerve. It also has communicating branch with ciliary ganglion. Now let's see communication branch to ciliary ganglion. Communication branch to ciliary ganglion from sensory root of ganglion. It is often mixed with sympathetic group. And next is long ciliary nerve. Two or three run on the medial side of optic nerve, pierces the sclera and supply the sensory nerve fibers to the cornea, iris, and ciliary body. The branches supplying the cornea contain one of the highest concentration of sensory nerve endings in the body and also carry motor sympathetic fibers to the dilator pupillae. The posterior ethmoidal nerve. It passes through posterior ethmoidal foramen and supplies the ethmoidal and sphenoidal air sinuses. Infratrochlear nerve. It is the smallest terminal branch given off at the anterior ethmoidal foramen. It emerges from the orbit below the trochlea or the tendon of superior oblique and appears on the face, above and medial angle of the eye. It supplies the conjunctiva, the lacrimal sac, caruncle, medial ends of the eyelids, and the upper half of the external nose. The anterior ethmoidal nerve. It is the largest terminal branch. It leaves the orbit by passing through anterior ethmoidal foramen. It appears for very short distance in the anterior cranial fossa above the cribriform plate here of the ethmoid bone and descends into the nose through slit of side of the anterior part of the crista galli. In the nasal cavity, it lies deep in the nasal mucosa, in the deep to the nasal bone. It gives off two internal nasal branches, that is medial and lateral to the mucosa of the nose. And finally, it emerges at the lower border of the nasal bone and external nasal nerve, which supplies the skin of the lower half of the nose. Now trigeminal ganglion second branch, that is maxillary nerve V2. It it contains the type of fiber sensory only. Its origin is from the middle division of the trigeminal nerve, from trigeminal ganglion, and it exits from skull from foramen rotundum. Its force is it's run forward on greater wing of sphenoid through foramen rotundum, enters the pterygoid palatine fossa, and divides into its terminal branches. Now the branches. First is middle meningeal nerve that supplies the dura mater of anterior half of the middle cranial fossa. Second is the pterygopalatine nerve, two small branches to pterygopalatine ganglion, that is sensory roots. Posterior superior alveolar, that is dental nerve, supplies the molar teeth, gingiva, periodontal ligaments, maxillary sinus mucosa. Fourth is infraorbital nerve, that is continuation gives middle superior alveolar, anterior superior alveolar, terminal palpebral, nasal and labial branches. And fifth is zygomatic nerve that divides into zygomaticofacial and zygomaticotemporal nerve, supplying the skin or zygomatic and temporal region and carries secretomotor fibers to lacrimal gland. And the terminal branches are infraorbital nerve branches, the terminal branches, palpebral that supplies lower eyelid, nasal that supplies side of nose, and labial that supplies upper lip. And the areas supplied are lower eyelid, upper lip, lateral nose, nasal mucosa, maxillary teeth and gums, and skin or zygomatic and temporal region. And the clinical relevance is that herpes zoster involvement, that is vesicles over uvula, tonsils, midface skin, causes odontogenic pain. And infraorbital nerve block, it gives anesthesia for upper lip, lower eyelid, upper cheek surgeries. Now, third branch, mandibular nerve, P3, it contains both type of fibers, that is sensory and motor, originates from by the union of large sensory trunk from trigeminal ganglion and motor root from pons. It exits from foramen ovale. In formation, its sensory and motor root pass through foramen ovale together, unite to form one trunk just outside the skull. And the motor supply are muscles of mastication, masseter, temporalis, medial and lateral pterygoids, tensor tympani, tensor vela palatini, mylohyoid, and anterior belly of digestion. Now its sensory branches are buccal nerve that supplies cheek mucosa and skin, auriculotemporal nerve that supplies auricle, external acoustic meters, tympanic membrane junction, temporal region, lingual nerve, it supplies anterior two-third of tongue, floor of mouth, and lingual gingiva. Inferior alveolar nerve that supplies mandibular teeth, terminates as mental nerve supplying chin and lower lip, and its terminal branch is mental nerve that is the continuation of inferior alveolar nerve and emerges through mental foramen to supply chin and lower lip. Now the functional highlights are it is sensory to lower face, mandibular teeth, anterior two-third of the tongue, and motor to mastication and related muscles. Now the clinical relevance is here that inferior alveolar nerve block, it is anesthesia for mandibular dental procedure. Lingual nerve injury, that is risk during third molar extraction and loss of sensation over anterior two-third of the tongue. And trigeminal neuralgia, it is B3 involvement causes severe jaw pain. Now the clinical aspects are now corneal reflex. Basically here There are afferent fibers and efferent fibers. Afferent fibers are carried through nasociliary nerve and efferent fibers are carried through facial nerve. So, tactile, thermal, and painful stimulation of cornea are detected by ophthalmic nerve, goes through trigeminal ganglion. There is right-left facial nerve via interneurons, then trigeminal nerve nuclei in brainstem, and orbicularis oculi to cause bilateral blinking actions. Now, herpes zoster ophthalmicus, caused by varicella zoster, predilection for nasociliary branch of ophthalmic nerve. Basically, here what happens, a person who has already infected with chickenpox has a dormant varicella zoster virus in trigeminal ganglia. So when it reactivates, it affects major nasociliary branch of the ophthalmic nerve and causes its symptoms such as rash, vesicles, pustule, crust, and permanent scar. There is also Hutchinson sign noted in herpes zoster ophthalmicus that involves crusting over nose and that indicates predilection of nasociliary branch of ophthalmic nerve. Supraorbital neuralgia, it is a rare condition characterized by chronic or intermittent pain along the path of supraorbital nerve. Nerve exits the orbit anteriorly via supraorbital foramen or notch traveling through forehead to provide sensory innervation to the forehead, scalp, and upper eyelid. Patients with supraorbital neuralgia typically present with persistent aching or throbbing pain in the supraorbital region and forehead, paroxysmal sharp or stabbing sensation, that is paresthesia or electric shock line pain, radiating along the distribution of supraorbital nerve, increased sensitivity in the area, sometimes described as painful hair on the anterior scalp, where even light touch or brushing the hair can trigger pain. And the treatment is supraorbital nerve block and injection of local anesthesia, sometimes combined with corticosteroids to reduce inflammation, is often both diagnostic and therapeutic. A supraorbital nerve block. Supraorbital nerve block it is blocked by injecting small amount of local anesthetic into supraorbital foramen. A 22 to 25 gauge needle is used. Foramen is palpated. The needle is guided towards the foramen, and once the periosteum is contracted, the needle is slightly medially, so that its tip is orbiting the rim of foramen. Following negative aspiration, 3 to 4 ml of local anesthetic solution is deposited. The supraorbital nerve is usually 2.7 centimeters from the midline. Now, supratrochlear nerve block. The supratrochlear nerve exits the orbit between the trochlea and supraorbital foramen. Supratrochlear nerve block is performed the same way as supraorbital nerve block, just site little more medial to the insertion site, described as supraorbital nerve block. Supratrochlear nerve is located 1.7 centimeter from midline. Now, superior orbital fissure syndrome. It applies to the lesions located immediately anterior to the orbital apex, including the structures exceeding the annulus of Zinn and often those external to the annulus, as multiple cranial nerve palsies may be seen in the absence of optic nerve pathology. Basically, what happens in the structures that pass through superior orbital fissure are affected here, and those structure includes third cranial nerve, fourth cranial nerve, via sixth cranial nerve, and V1 branch of ophthalmic nerve, and also involves superior ophthalmic vein and sympathetic fibers may or may not be involved. So the presentations are also involved like this. If oculomotor nerve is involved, it leads to ptosis, then down and out eye, dilated pupil, and fourth nerve is involved, there is impaired downward gaze. If sixth nerve is involved, there is loss of lateral gaze. If V1 branch of ophthalmic nerve is involved, there is numbness or paresthesia of forehead, upper eyelid, and cornea. And if sympathetic fibers are involved, it leads to Horner syndrome that presents with ptosis, meiosis, and anhidrosis. And if superior ophthalmic vein is involved, it might lead to proptosis and orbital congestion. Orbital apex syndrome. The basic difference between the superior orbital fissure syndrome and orbital apex syndrome is that it involves the involvement of optic nerve, that is second optic nerve. Because the orbital apex is present medial to superior orbital fissure, so in this condition, there is also vision loss is present. So orbital apex syndrome involves damage to third cranial nerve, fourth cranial nerve, sixth cranial nerve, ophthalmic branch of trigeminal nerve, and also optic nerve. And because of the optic nerve, there is also clinical presentation of vision loss. And the rest other are same like superior orbital fissure syndrome. That is monocular diplopia, ophthalmoplegia, periorbital pain, proptosis, ptosis, ocular deviation, headache. Now, cavernous sinus syndrome. The difference between superior orbital fissure and cavernous sinus syndrome is that superior orbital fissure involves only V1 branch of ophthalmic vein, whereas cavernous sinus syndrome involves V2 branch. That is, it involves cranial nerve third, fourth, sixth, and V1 and V2 branch of trigeminal. So clinical presentation will also be like this: sensory deficit of the nerves, vascular congestion, proptosis, chemosis, ophthalmoplegia, and elevated IOP. Now the Tolosa-Hunt syndrome. It is caused by non-specific granulomatous inflammation of cavernous sinus, superior orbital fissure, or orbital apex. And the pain in this syndrome results from the inflammatory involvement of the first division of trigeminal nerve. And the symptoms here are ophthalmoplegia, diplopia, dizziness, nausea, neck stiffness, and blood vision. Now, infraorbital nerve block. Anesthetize the ipsilateral lower eyelid, upper cheek, side of the nose, and upper lip, and can be used in the procedure in these areas. Now, damage to trigeminal nerve during surgery. During cancer surgery, the tendency of squamous cell carcinoma to affect the cutaneous branch places this nerve at risk for injury during surgery. The ophthalmic branches, that is frontal, supraorbital, supratrochlear, lacrimal, and nasal, can be injured during eyebrow surgeries, and all patients in whom coronal incision was made complained of forehead numbness and paresthesia. Now, trigeminal neuralgia may involve one or more of the three divisions of the trigeminal nerve. It causes attacks of very severe burning and scalding pain along the distribution of the affected nerve. Basically, what happens here is uh, is that uh, trigeminal ganglion, that is its sensory root, when it enters the pons near the brainstem, there is the most common artery involved, that is superior inferior cerebellar artery. It is that uh, it comes in contact with the trigeminal sensory root and it rubs it, so that there is demyelination of the trigeminal ganglion and it sends erratic nerve signals that causes sensory attacks in trigeminal neuralgia. And the pain is relieved by injecting 90% alcohol into the affected divisions of the ganglion or by sectioning the affected main sensory root or the spinal tract of the trigeminal nerve, which is situated superficially in the medulla, it is medullary tractotomy. Now, to summarize this, the V1 ophthalmic nerve divides into frontal nerve, lacrimal nerve, and nasociliary nerve. Frontal nerve further divides into supraorbital nerve, supratrochlear nerve. Nasociliary nerve divides into long ciliary nerve, anterior and posterior ethmoidal nerve, infratrochlear nerve. Maxillary nerve has meningeal branches, ganglionic branches, posterior superior alveolar nerve, infraorbital nerve. Now, ganglionic branches are greater palatine nerve, lesser palatine nerve, nasopalatine nerve, and nasal branches. And infraorbital nerve has anterior superior alveolar nerve, middle superior alveolar nerve, and zygomatic nerve has zygomaticofacial and zygomaticotemporal nerve. Now, mandibular nerve, it divides into nerves, nervus spinosus, motor branches, anterior division, posterior division. Anterior divisions are the nerve to lateral pterygoid, mesenteric nerve, deep temporal nerve, and buccal nerve. And posterior divisions are auriculotemporal nerve, lingual nerve, inferior alveolar nerve, which gives branch to nerve to mylohyoid, and mental nerve. Now, branches of the ophthalmic: frontal, lacrimal, and nasociliary. Frontal is the largest of the three branches. It divides into supraorbital and supratrochlear. That gives supplies to upper eyelid and conjunctiva. And supraorbital goes innervation to scalp, and supratrochlear gives innervation to forehead. Now, lacrimal, it is the smallest of the three branch. This is branch from zygomatic nerve of cranial nerve V2, containing parasympathetic fibers, and it gives sensory innervation of lacrimal gland, upper eyelid, and conjunctiva. Contains parasympathetic fibers to lacrimal gland. And now nasociliary now, it divides into anterior ethmoidal, that gives sensory innervation of mucous membranes of frontal, ethmoidal, and sphenoid sinus and nasal cavity. Posterior ethmoidal now, absent in approximately 30% of people, sensory innervation to mucous membrane of sphenoid sinus. Infratrochlear nerve, it bridges of nose, upper eyelid, and conjunctiva. And long ciliary nerve, that is sensory innervation to eye, that is cornea, ciliary body, iris, contains sympathetic fibers to dilate the pupillae muscle. Thank you.